right. Well, it is 2 o'clock, so we're going to go ahead and get started here. Thank you both Shane and Elizabeth for being here to go over our ChartSpan webinar with Burrows Consulting on chronic care management. And I will now turn it over to Shane, our speaker today. Thank you all.
Hey, I'm going to talk first, Hannah. You were excited. Okay.
I'm sorry, Shane has the slides, so I thought he was going first. Elizabeth, you have the floor.
All right. I'm going to get started. Hopefully I can rattle on for a couple of minutes while everyone gets connected. As we know, we always have some late joiners. So my name is Elizabeth Burrows, and I'm founder of Burrows Consulting, and we're excited to have ChartSpan with us today. Shane's going to be sharing all the details, but I will tell you, every day I get called, every single day. I swear not a day goes by, at least a weekday, that I don't get called and somebody wants money. Okay. And typically they want grant money, and I'm all about that. I'm all about grant money, of course. That's what I do. I'm also all about getting people extra money for Medicare and Medicaid, of which I do a lot of that too. But this is another way that I don't do this, and this is through chronic care management. And this is the best money because this is your reimbursement money that doesn't have all the strings attached that my grant money has. Okay. So this is the best money because you can use it and reinvest it into the great things that you're doing at your rural health clinics, your FQHCs, or your hospital and provider-based clinics. I also want to say, on a personal note, chronic care management is extremely important to me. I'm going to tell you 2 stories. One was while I was a CEO at an FQHC lookalike in rural Indiana. And we outsourced chronic care management. People said, the doctor said, why are you outsourcing this? Well, guess what? We didn't have the staff. I didn't have enough MAs. I didn't have enough LPNs, RNs, or staffing to fill my own clinics and to staff at the hours that we needed to staff it, 12 hours a day at some, 8 hours a day at others. So I had no staff, and I had a small staffing pool in rural Southern Indiana to draw from. So I literally didn't have the people to offer CCM services myself. At the time, I made a little bit of a controversial decision to outsource it. And at first I had some people complaining. Within the first week of our services, we caught one person having a heart attack while on the call, had an MI, had to call an ambulance immediately, saved that person's life. I don't know if they would have lived or died without the CCM, but I do know that we caught that person and we helped them and saved them. The other one, we had a person that was continually falling. She kept falling. We were trying to get her approved from MRIs. We had her in therapy, specialists, neurologists, driving hours to see all these specialists, couldn't figure out what was wrong. During a CCM call continually, the MA on the other end of the line kept hearing the patient talking to, hey, get down, Blackie, get down this cat, get down Whitey, get down this cat's name, Fido, or whatever the cat's names were. Found out within her trailer, she had over 20 cats running around in a small single wide trailer and had other people living there. No wonder she was falling all the time. The cats were literally tripping her. And we were only able to identify that due to CCM. So think of the tens of thousands of dollars saved in additional services and the time of that rural patient traveling up to the big city and stressing out over all these tests. So those are 2 stories. And then on a personal, so those are my 2 stories, CEO stories. On a personal note, my grandmother, who's now in heaven, but during the last couple of years of her life, at one point, she had stayed out of the hospital for months. We thought, this is great. This is wonderful. And then something changed, and she was getting really sick and was going in and out of the hospital, in and out of the hospital. And, 3 or 4 days in the hospital, we get out, go back in 48 hours. It just was not a good time over that month. And we figured out what had changed. And after weeks of trying to identify that, the one change was that her chronic care management nurse was on medical leave. So she was no longer getting her Monday morning check-ins from the CCM nurse at the local rural FQHC where she got care. And that one difference meant that she spent most of a whole month in the hospital and was not able to be at home on our family's farm where she was happy. And so again, those 2 reasons are why I present Shane and the work of ChartSpan today. Again, this is great chronic care management. And if you can do it with your own staff, wonderful. I've never had enough staff to be able to provide that service. And so this is an option for many of you that are staff limited, especially in the great resignation time period we're in, and ways that you can provide these services. And I'm sure you would have similar success stories. So now I turn it over to Shane. Thank you.
Thank you, Elizabeth. And it's a pleasure to be here. And this is something hopefully that everyone will see. We're very passionate about it as well on patient care and overall outcomes. And so really that's what today is about, really to dive into the program in a little more detail and really understand all the true values of the CCM program and really what the opportunity looks like outside of just some of the traditional value layers that we all understand. I want to provide a little bit of kind of background on the CCM program itself and just talk a little bit about kind of where it's come and kind of what we're seeing from a trend standpoint. But the actual CCM program itself was launched in 2015. It started in stealth in 2013 and 2014. The results were very favorable. And as that came to fruition in 2015, CMS decided to launch it fully with a CPT code 99490 and began reimbursing for that non-complex care. Since then, they began to expand the program. In 2017, they made some adjustments to allow for verbal enrollment. You didn't have to have them come into the practice and sign a piece of paper. In 2018, they expanded some more new codes, which were called complex codes for more complex acute cases with longer time, higher reimbursements. In 2019, they introduced what they call principal care management. That's really kind of more focused on subspecialists with single comorbidities. And then in 2020 and 2021, the fee schedules, they expanded more codes for additional time. And then in 2022, we really had probably one of the most transformative moments in which they adjusted the RVUs, almost doubling the reimbursement of the code without changing the requirements of the services, which is almost unheard of, but it's really transformed this industry to really produce more value for this type of a program. And then this year in 2024, as we were reviewing the proposed rules, they're looking to do some additional expansion with the G0511 code for those of you that are in RHCFQ, some of the overall care management kind of parent code. So more to come on that. We'll see what they finalize here in a few weeks here in November. One of the things, though, we do like to talk about is just if you think about the overall code itself. And so it's really the non-complex CCM care is by far the most pervasive codes that are used. And so for our RHCF, QHCs, critical access folks, that would be the G0511 code, which is the culmination of about 6 different codes. It's the average. The reimbursement for that is around $73 and change. It can vary on your geographic adjustment factor. And for those that are traditional facilities, right here, you can see it's the $65 roughly, depending on your adjustment factor for the 994 and 90 code. But it's by far the most pervasive because it's the most frictionless code. So, again, for patients to be eligible, they had to be diagnosed with 2 or more chronic conditions. They had to have been seen by the rendering provider in the last 12 months. They have to have Medicare Part B or Medicare Advantage, or can be dual eligible, Medicare, Medicaid. And as long as they meet those requirements and you obtain written or verbal consent, and you can document 20 minutes or more of outsourced or in-house care, you can bill that code once every 30 days. So it's 12 billing cycles a year for the non-complex codes. Now, when Medicare really was, envisioning this program, if you kind of want to think about it in terms of kind of how we adjust to kind of our risk kind of categories here with the cohorts of patients, really what it wasn't designed to do was to really focus on the high utilizers. The high utilizers really is for things like case management, things that we're aware of, bolt-on nurse, home health, those types of things. What it was trying to do was to establish a program that could really kind of more focus on the bolus of patients, the larger cohorts, which are going to be your lower risk and rising risk patients, and establishing a program that could help kind of fundamentally establish a more preventative relationship between the provider and the patient to keep them from moving into those less profitable centers like the high risk categories and keep them on a more preventative track. The problem with that is, as you can see, that's 70 to 80% of your typical cohort. So now you have operational complexities, scaling complexities that are required versus a very small cohort, such as your high risk utilizers. So with that, kind of we look at the operational workflow of CCM. This is kind of really where we've established as an industry what really needs to happen when deploying it appropriately. This is a managed service example here, but this is really whether you're doing it, through an outsourced partner or you're doing it yourself. The tenets of what you need to do are still transcend either. And it really starts with data. The data integration is really, really important, and ensuring that you have the ability to extract reports that you need to be able to identify eligibility, and to be able to, if you're using an outsourced partner, push data back into your EMR. Because we all know the last thing we want to do is to saddle your providers with another disparate system they have to go into, or another button that they have to push. So ensuring that you have that tight integration is really important. The eligibility, though, is also one of the first steps in establishing a program too. And so the eligibility is being able to comb through those reports and identifying, what patients are eligible, and not just the typical requirements for CCM, but taking it a step further, because many of you probably participate in an ACO or other value-based arrangements. So you want to understand what your attribution looks like. So are these patients attributed to a specific plan? And if they are or aren't, are they good candidates for the program? The next thing, which is really important, is education. And this was a lesson that the industry learned, I think, early on, was how do you get patients to want to adopt the program in mass scale? And we're still figuring it out, but a lot of what we've learned is that education and educating this patient cohort is very, very important. And when we say educating, it's making sure that they have access to information about the program. Why was it created? Whether it's physical collateral, whether it's digital collateral, whether it's providers talking about the program. Medicare patients are inundated with noise of scams and people always trying to sell them something. So it's very hard for them to understand, what should I really listen to and what shouldn't I? The next piece is enrollment. How do I get patients enrolled in this program? It requires a consent to be obtained before you can begin the clinical services. And again, that's really hard. How do you do that? I've spoken to organizations all over the country. That was kind of the showstopper for many of them. Is I'm not a digital marketer. I barely know who was available, but being able to market to them effectively was difficult. And so understanding what tools are available, again, whether using an outsourced partner or trying to do it yourself, but making sure you have the educational pieces of it and someone or something that's dedicated to being able to market. That's really the only way you're going to achieve any real level of scale. Now, we put some brackets around this, and it's important to note that when we look at any value-based program, that churn, there is a factor of churn that we need to understand. And so I'll kind of explain that. So when we think about churn, there's churn in and churn out. Churn out is either going to be voluntary or involuntary churn. With involuntary churn, we can't affect that. That's when patients expire, they move into long-term care, they move, or they're just no longer need or qualify for care coordination or CCM. Voluntary churn, however, are those patients that could stay in the program, but unenrolled or remove themselves from the program because they didn't find value. And we all know that longevity is really key for these types of programs. So really trying to focus on the patient experience, because they're really the primary consumer of this. They have to agree to be in the program and can decide to leave at any point in time. But thinking through the lens of how they view and edify these types of services is really important. And I'll talk a little bit about some statistics we found on that in just a minute. But focusing on the voluntary churn and understanding the churn in factor. There are more patients churning into Medicare every single day, every state in this country. So making sure that we have a system in place where you can pull those reports and identify newly eligible patients, educating them on the program, and then having an asset or tool that can market to them is vitally important to achieving what we call net patient churn. Of course, you'll need a clinical engagement team. These will be your nurses, your team that will actually deploy the 24-hour work for the CCM program. Utilizing a population health department that'll work closely with your alignment with your quality programs and how those programs align and how you can actually achieve better outcomes, which we'll talk about more here in just a minute. The billing component, is it a manual entry, or do you automate the process and being able to do that in real time so you don't have things push out is something else that we have to think about and talk about. And then also making sure that there's some level of quality, some kind of quality systems in place that sits on top of the program so that you ensure you're doing things like recording your phone calls, making sure that your clinicians are having the best interactions, or some way that you can have coaching and remediation, just like you would anything else. And then even the patient services department, The patients have questions, patients have concerns. They're going to want a place they can go to understand this EOB they just received, or they couldn't get somebody up on the phone. What does that mean, and how do they use the program? So having a resource available for them to be able to ask those questions instead of just unenrolling or just removing themselves is really vitally important to a successful program. As we kind of work ourselves sequentially through the process, as we talked about enrollment and so in education and why it's so important, there's tools out there, and there's really a cadence that we've seen over time that's really established itself to be productive in the educational piece of it. And it's doing things like good old-fashioned mail, sending them a letter in the mail, and explaining this will be a program that's now become available to them. There's a tool that we happen to use at our company called Ringo's Voicemail. That's a place where your providers can actually record a 10 or 15-second voicemail. We'll put it on the phone of the patient using that software. And then after that, they'll receive maybe their letter, and then they'll get the follow-up call from the consent and enroll specialist. But little things like that, providing collateral there at the practice, a little trifold or maybe a poster, making sure that the provider understands what is the CCM program when maybe their patients ask about it. They can have a 30-second conversation with them. All of these little steps along the way is really what's going to soften the market so that you can potentially achieve a nice level of scale so that we can move the needle in terms of quality outcomes and overall patient encounters. Onboarding is also something that's very important. We've learned this lesson as well. A patient does decide to enroll in the program, well, then what's next? Are they just going to start getting phone calls? Well, what we've learned, just like anything else, when we've joined something new, like a gym membership or anything in our lives, there needs to be some level of education and onboarding. So we mail out a welcome packet. And this packet has things that has their name printed on it and walks them through the program. Here are some ways to utilize it. And a welcome to CCM phone call so that we can get to know them better, answer any upfront questions they maybe have, or maybe address any issues before we move over into starting to work the care plan and establishing that ongoing relationship. But all of these little steps, if you follow them the appropriate way, will establish a program that can ultimately achieve a nice level of scale. Now, we're seeing some interesting patient behavior trends that I wanted to talk to the group today about, which probably won't surprise you too much. But one of those is that patients are wanting to utilize a more multimodal approach to their engagement with their clinicians. What does that mean? That's a fancy way of saying they want to text more, they want to use your portal, they want to use other technology components to supplement their engagement. Not everything has to be done over the phone. The majority of it will be, but they want to use other channels to interact. So it's important to be thinking about that. I want to show you some statistics here. The first thing we want to talk about is some of the data points that we've seen internally. We've done numerous focus groups, and when we done these focus groups, we asked them numerous questions about value within the CCM program. And what was really, really interesting to us was that the number one thing that patients said they want above everything else by a factor of 4 was that they wanted fast access to their healthcare clinician, their CCM nurse, almost immediately, 24 hours a day. That was the number one thing they found value in. And if you could work around that, that would really achieve success in their minds. So thinking about SLAs and how you would deploy this is really important, because before we can start asking things of patients, we have to provide value in their eyes. Here's an SLA, for instance, with our company. So we actually manage our business to 30 seconds or less. Our actual last quarter was 17 seconds. So if you think about that, it takes a lot of work to be able to have those performance metrics in place. But when you're a patient that is most likely paying for a service, and you call them and they call us at 2 o'clock in the morning on a Sunday morning, and within a ring or two, they have a nurse picks up the phone, has their chart pulled up, and is able to triage whatever need they need, that's value in their eyes. And that's how you're going to really achieve longevity. And that's how you're going to get them to do the other things you need them to do, such as certain assessments or come in for certain preventative types of services. Voicemail response time, kind of the same thing. We manage to 5 minutes or less, and our actual was 3 minutes and 49 seconds. Texting, we just mentioned just a little while ago. Here's some statistics around what we've seen industry trend in texting. 5-6 years ago, we were doing no texting at all. I think by the end of this year, 2/3 of all the patients across 6 time zones are going to be using the HIPAA text function in some capacity as part of their interaction with their clinician. Another really interesting thing was we were finding some friction points around the interaction between the nurse and the patient, and how that would manifest itself would, you might get a roster of patients. Nurse needs to work every month. And then what does everybody do? At the beginning of the month, the nurse begins calling the roster, just going from top to bottom. Now we're calling these patients when it's convenient for us as the deliverers of the service, not when it's convenient for the patient. In fact, the data was showing us that only around 18% of the time were we actually getting the patient on the phone. It would require a callback and then changing of calls. It was just a choppy experience. We said, what if we do something different? And what if we're able to establish an appointment or the date and the time of when the patients can establish, here's when I want to have my interaction with my CCM nurse. And that's essentially what we deployed. And so by the end of this year, I think almost 75% of all of the patients have now begun utilizing this service. And our engagement percentages went from 18% to 87% on that first call. And why that is important is because when you have 3 to 4 minutes to do your pre-call prep work, and the CCM clinician has time to know what they want to accomplish on the call, make sure they're referencing things from previous calls, have their plan in place, and make sure that's the most effective use of time, it's a much differently experienced positively for the patient than I've got 10 seconds to prepare for this call in, and then we just kind of have to work it from there. Now, as we kind of get the patients going and you begin to operate the overall program, you think about the clinical services and what are some of the things that we're seeing and that are important. First and foremost, really, especially since the RVU went up in 2022, we've seen is that really this is a nurse-led program. There are some organizations, including ours included, in the early days, we're utilizing MAs, health coaches, CNAs, and not that there's anything wrong with that, but what we've really found for longevity and the ability to deploy the program, we found the satisfaction scores are showing us that achieving the levels that we're needing, it really is become kind of leveled as a nurse-led program. So things like being able to assign specific nurses regionally so that the nurses in the org are assigned to each other is important. And really, most importantly, that the clinician and the patient are assigned to each other. So it's nurse to patient. It's the same reach out nurse interacting with them. They can develop that rapport. They can develop that level of trust. And they go on this relationship and they go on this journey together. That's really where we're seeing the highest level of engagement and longevity when we deploy kind of a established nurse-focused program. Now, in regards to the overall kind of clinical structure, in the early days when CMS first rolled the program out, like in their kind of normal ways, kind of being nebulous in terms of what are the types of things that you should do month in and month out. There's you kind of have an idea, but there needs to be some level of structure kind of annually around this now that we're going into 8, 9, 10 years into this program. And so here's some examples of kind of some things to think about. Now, there's a lot of text up here, but we think about this now in kind of annually, kind of month and yearly terms. And so, there's kind of months 1 through 4, there's the typical types of things that you want to look at, you want to try to achieve, and months 5 through 8, and then months 9 through 12. Now, of course, things are going to change, and it's very, very fluid depending on what's being self-reported, the diagnosis of the patient, what's occurring, or there's an acute event. Absolutely. But we kind of have an overall goal, and that's important. Now, what doesn't change, and what is really the hallmark of this program, is that there's this constant cycle that's occurring behind the scenes. It's really the foundational element of CCM, in my opinion, and that is we're constantly taking inventory, identifying issues, and intervening, and then reporting back. That never ends. We're always asking questions, looking for issues, and then figuring out what's a solution to that issue and how do we want to intervene. So that always occurs. That's never ending, regardless of tenure in the program, what's occurring specific to that patient. Now, when we think about annually, we think, well, if we're running a CCM program and if it is effective, what should we expect, each year? So there at the bottom, those are examples of kind of what we could typically will accomplish in a year with a program in our CCM program. So, you can look at what are the number of assessments that we typically try to complete. How many engagements are we having each year? Conditions, are we detecting and identifying additional conditions that maybe aren't being reported currently in your EMR, or care gap or patient assist? Those are the care gaps. We identify that there's open care gaps and assisting them with those needs. And then taking inventory, how did year 1 go? What did we accomplish? What are we looking to do in year 2 based on the care plan, the diagnosis, and the acuity of the patient and those comorbidities, and then continuing, on that program. Now, system of record is really important. And as you think about, how do we report on what we're completing and how do we edify it? It's important to understand is that, it has to be voluminous, but usable at the same time. And so this is an example of what our company creates. It's called the PHS, the Patient Health Summary. But your system needs to have a place where all of the information is housed and it's easily accessible, both for the provider and the patient, which is a requirement by CMS, by the way. But things like this is ultimately this is a culmination of what did we extract out of the out of the EMR, essentially what's the care plan that's been established, but then what is the patient self-reported, what have we identified outside of your practice or organization. So if a patient has had something completed or went somewhere, getting that record in and making sure you take the salient points from that interaction and housing it here in this document, making sure you have things like timestamp capabilities so that what was discussed. It's one thing to know what was discussed, but why was it discussed and for how long and what was completed each month. Having that kind of running record to understand kind of what's been completed each month is really important. Or doing things like, putting little badges so that if something maybe has changed in the last 30 days. Some provider feedback that we've had is things like putting a thing called this patient status update there on page 1. And that's really just, have they been to the ED? Have they had a new medication prescribed? Have they gone to see a specialist? I want to know that right away. Let's put that there so I understand that before I go dive into this further. Let's talk about effectivity. So now we've kind of talked about the operational piece, a little bit of the history, and kind of really how to deploy it. But if it's done the right way and we really harness the CCM program, well, what's the real opportunity here look like? So there's really kind of 6 value layers to the overall value proposition. And so it really starts with fee for service. So when we say fee for service, this is really what funds everything. And so that's just simply the reimbursement you receive for billing those codes minus your cost. So whether you're outsourcing it to a managed service partner or there's a cost deployed to your nurses to do this yourself, typically we're seeing between $250 to $500 per patient per year is the profit opportunity for billing those codes minus your fees. But if it's done right, it's done the right way, where are the other areas that really can bring some value? For instance, one of the things that we've seen looking at our own data is that we've been able to show a dramatic impact on shared savings performance. So these, for patients that are attributed to your ACO, you're going to get the fee for service reimbursement, but you're also going to perform better in your ACO. And most CCM companies, ours included, don't take any of this. This is just a byproduct of a well-run CCM program. Maybe your quality performance, your QIP, your MIPS, your quality measure of performance overall, utilizing the program to help you perform better in those various measures leads to higher reimbursements. ACO and APM beneficiary attribution, that kind of black box, that formula that CMS uses for beneficiary attribution, a lot of it is based on plurality of care. That means how many codes are being billed, how many preventative services, are they having an annual wellness visit? Taking all of that in, and that's how they assign attribution. Well, using a CCM program, especially one that's good at identifying patients that are newly entered into Medicare, getting them enrolled and getting them into the program is a fantastic way to not just getting them on more preventative workflow, but getting them attributed to your program or to your entity. Again, that there's dollars that equate to that. Leakage mitigation, for those that are part of larger institutions that are held accountable to keeping things kind of in network is a great way. CCM is a great way to help mitigate some of that. We're essentially kind of the quarterback or the central core of the care coordination, the coach for those patients. And so if we have the ability through established workflows to offer up opportunities to have a colonoscopy completed here or a mammogram, whatever that might be, that's a way that revenue and services might leak out outside of your network just by not having any eyes or control over that. And then lastly, we're seeing the data is showing us that we're seeing an increase in overall E&M encounters. These are typically more office visits because we're affecting some of the social issues such as transportation or other issues, or identifying conditions or needs and getting those appointments scheduled. We're seeing roughly about a $216 per patient per year increase in more preventative services. We track that year over year. And a lot of times, a lot of us getting an annual wellness visit scheduled or pneumococcal vaccine, whatever it might be. Here's some specific data I wanted to share from my company at ChartSpan. We tracked our 2022 data, and one of the things that we wanted to do was to analyze the performance of patients that were active in the CCM program for the 12-month period of the year, and compare that to patients that were at the same practices but were eligible but did not enroll. And what did the data, comparative? Let's look at the data here. The dark color, the dark blue, are the patients that were enrolled in the ChartSpan program, and the light blue were those that were eligible but did not enroll. And the data was really interesting. In fact, the claim count was actually higher, which in our opinion is a good thing because they're having more claims, they're having more interactions, they're coming in for more office visits. But look at the average cost per patient. There was almost a 20% reduction in the overall average cost per patient each year. So there was a dramatic impact in the overall cost of spend, which goes right back to your quality measure or your ACR MSSP performance. Then we looked at a couple of things. We wanted to understand maybe ED, was there an impact on number of ED visits? And then if there was an ED visit, was there an impact on the overall cost? And so as you can see, there was a slight reduction in the overall claim count. And if there was an actual ED visit, there was roughly about a 12% reduction in that overall cost as well. And then the last one, those were for those of you that are attached to hospitals or critical access or to a system. We know readmission rates are one we all obsess about. And so we wanted to look at, was there an impact between the CCM program and readmission rates? As we looked at the data, we found some interesting trends here. With the less than 30 days, we were able to reduce it down by about 13% for the enrolled versus the eligible but not enrolled. But then look at post 30, and even when we get into greater than 90, it ultimately almost eradicated itself. And so that's just goes right back to the bottom line. Again, like for us, for instance, we don't get any of this, but that's just a nice byproduct of a well-run CCM program. And again, it goes back to how do you harness the overall value of the program itself. In terms of kind of how the workflow works, and we think about pop health and the quality programs, we say, okay, that's great, we're running the CCM program, but what's the workflow? Like, how do I actually do it, and how do I actually deploy it? And so the best way to do this is to work with your quality team and to establish what we call the care list. And so the way we typically do it is we'll look at open care gaps that are assigned to specific patients, and then matching those patients to those that you have enrolled or active in the CCM program. So we know where the care gaps are, we know which patients are in the program, and then having the ability to either through a manual process or through an automated process within software like we do, where it basically notifies the CCM nurse that, hey, I need to talk about these 2 or 3 things with these patients this quarter. So they understand, hey, this is something I need to bring up, and this is something I need to discuss, and depending on how they answer their questions will dictate, what we do next. So for instance, I might ask, hey, it looks like you're due for a colonoscopy. Have you had it completed in the last 12 months? If they say, no, I haven't, well, we train the clinicians, and a good CCM nurse will know, well, my next question needs to be, would you like me to help work on getting that scheduled or coordinating that? And having an established workflow that's already been put in place between the team is really important. So then you can help establish that and hopefully follow up. And that's kind of where that leakage mitigation typically is kind of manifests itself. Now, let's say, for instance, sometimes we do get, the patient says, yeah, I had it completed. I was actually down in Florida. I was down there for the winter when we had it completed. Well, they had it completed, but you're not getting numerator credit for that measure or that care gap at that point. So following up on that, going back and requesting those electronic records from that provider or that entity, verifying that it was completed and uploading it in the system, and then notifying either the organization or the team so that you can get numerator credit, again, is a fantastic way to harness this program. And that's how you're going to get additional dollars and get additional funds by utilizing a program which you get paid the time to do it. So that's just a terrific workflow here. Some other data points I want to show you as we kind of looked at this. Our thesis was we were impacting overall quality measure performance, but we wanted to again compare it for patients that were enrolled in the CCM program compared to those that were eligible but not enrolled. So like the cost reporting, we looked at specific measures. And so the dark blue here are the patients that were enrolled and participated, and the green were eligible but not enrolled. And as you can see, these main kind of measures here that we would track and work with, the CCM enrolled outperformed in every category. So there are dollars associated with that performance, especially social determinants of health. That's a major thing that we're all focusing on is SDOH screening and follow through. And so we almost tripled that number compared to those that were eligible but did not enroll. So with all this, so we're kind of thinking about harnessing this. And so what does it ultimately mean in potential revenue opportunities? So what does a revenue projection typically look like? So what we did here was we just took an example here for those of you that are with the RHC, FQHC, critical access for the G0511 code. How does the economics of it actually work out? Now, this is just for fee for service. This doesn't include kind of that will at 2 through 6 of these other things. There's a lot of revenue and value attached to that, but it's just kind of hard to quantify it unless we specifically break it down for each individual org. But overall, what does it look like here? So if you're an organization of decent size, and you've got around 1,500 total Medicare Part B, Part C, or dual eligible patients, typically what we're seeing is about 82% of those we're finding are eligible. Have been seen in the last 12 months, have the right payer mix, have been diagnosed with 2 or more chronic conditions. So when you down convert that into the eligible population, that's an important data point, because that's who's eligible to be in the program. That's kind of where you want to start when you're comparing your projections. Converting them into the program is, again, really hard. That's a hard step. That's that education and enrollment process. Here at ChartSpan, and kind of what we're seeing at the top performing organizations that we've seen, about 55% is about the best enrollment that we're seeing. So that's what you could expect. Roughly, you should see of that eligible population. Typically, it takes anywhere between 3 to 6 months to get to that number, because there's time and just time you have to work through these lists, having these discussions with patients. I get asked all the time, why isn't it higher? And the number one reason, in my opinion, really is it's mainly the cost share, the co-insurance. That's the number one friction point for this program. But at 55%, even at that number, what does that look like? So at 676 patients enrolled in this example, you move over there to the middle column under the financial breakdown, the reimbursement for typical RHCs or FQs is around $78 and change. So that's for the G0511 code. Remember, it's around low 60s for if you're a PPS or a traditional facility. A managed service fee is what you're going to pay an outsourced partner like our company. You do need to associate, kind of, you look at the P&L, you look at the opportunity, there is a fee to run the program. You're going to have to either hire your own nurses, have your own software at some capacity, but what does that look like? And that's kind of how you can compare the real profit opportunity. In this example here, though, you can see what the net profit is. It breaks down to almost a 50-50 split. It's around $38.85 is what the net profit left over with that specific code. So if we look at kind of this year one, what does that look like in annual recurring profit? That's almost $300,000 in new profit revenue just on the CCM program that's available to you, whether you outsource or insource this at your clinic. So all of that can be done while beginning to utilize it to gain the other revenue opportunities in your MSSP performance and your quality performance and more services, annual wellness visits, even more E&M encounters. If you added all of that together, I bet it almost doubles that number in the real opportunity in terms of profit. In over a 3-year period in this example here, we're talking about we're getting close to $1 million over a 36-month period. There are very, very few programs that are available out there today for those listening, where there's very little to no upfront resource allocation or capital expenditure to get this type of program turned on. And the value that you get out of it outside of just fee for service is really untapped. And we're really just at the early stages of understanding its true value potential. So as we kind of think about what are some of the overall key takeaways for the program itself, and first and foremost, just remember, CCM is here to stay. It has done nothing but expand since it was launched in 2015. And the Medicare population is growing. The demographic is changing. We're having more patients move into Medicare and off commercial insurance. So you need to be thinking about, am I capturing these dollars? Am I capturing and make sure that I have the services in place for my demographic that is changing? Patient adoption is also accelerated pretty dramatically. COVID had a lot to do with that. The pandemic, I think, accelerated the program, in my opinion, by about 5 years, because there was a period in time where patients were forced to seek out alternative ways to interact with their providers. They're adopting telehealth more. They're utilizing technology more. As to my next point, they're texting. They're wanting to utilize more of this. Almost everybody has a smartphone now, or a tablet, or some capacity, some kind of a device where they can utilize that technology more. So lean into that. Understand where are some of the ways that you can supplement those interactions. The other thing to think about too is that the market has matured quite a bit. There are more deployment options available. There are numerous companies out there that are highly capitalized, that have been doing this for a very long time, have learned the early lessons. There's a lot of really great software out there. There's a lot of opportunities. There's really no excuse any longer to not look at a deployment option as you kind of look at this year and moving into 2024. And essentially, these are federal dollars that have been allocated to you that we're not tapping. The millions, the tens of millions of patients that were eligible for CCM, a single 1 to 2 maybe percent point of patients were actually enrolled in the program and utilizing the services. And these are just federal dollars that we're not accessing. CCM can assist in those care gap closures. We kind of just talked about that workflow. It's just a tremendous value add. It can improve MSSP performance overall. The data we have proves that it can perform that even with that additional fee for service. And it can potentially help with beneficiary attribution. That's kind of that black box that we're all trying to figure out how to get more patients attributed to your overall program. So with that, that's the end of the presentation portion here. I don't know if we have any questions we want to answer. Elizabeth, I don't know if you want to add some closing comments. I'll have your contact information up here.
I did actually have some, feel free to put your or questions in the chat if you do have any more, but I did have some submitted with the registration. So can you go a little bit more in depth about maintaining appropriate documentation for CMS reimbursement and compliance? Maybe just a brief overview if you have anything to acknowledge that question.
Sure. Yeah, you need to have a system of record or something that is more than just a spreadsheet. You need to have something that can show this is what was done, this is what was completed each month, this is who did it, and making sure you just have appropriate controls in place so that it's not something that's easily manipulated. But as long as you have that document or that system to where you can show if CMS does or the payer does require some supporting documentation that you can PDF and that you can set as part of that code, you should be fine. Most all of the organizations that offer CCM services, whether it's a software module or a software only company or an outsourced partner like us, we build all of those systems and controls in place so that when you do have that work completed, you'll know who did it, how long they did it for, why they did it, and then having it in a place that someone can't really change or manipulate. I think as long as you have those in place and you have an easy way that you can send it off, you should be fine.
Thank you. And again, these questions will also go out in the Q&A that I'll send after this. We had a few more in the chat as well. Another one, what is the best way to track portal and text communication in terms of time tracking to meet that 20-minute requirement?
That's a really, really good question. It's one, in fact, that we're tackling ourselves right now. You need to make sure that you have a software or some way to be able to track that. Again, one that's auditable and that's in a controlled environment, in our opinion. So if you are texting or if you are utilizing technology as part of that time, just making sure, I think, that you establish what those parameters are, how you track it, and then making sure that it's defensible. If you're just exchanging a text message with the patient and that's all you did, well, you're going to need to show you did more clinical time. You need to have more interaction. So it's probably the next major kind of expansion for a lot of companies that are rolling out CCM, because most of it was all telephonic in the early days, but now that we're utilizing more technology, I think it's ask the vendor, maybe look at your own software modules or your software entities if you are going to utilize those other modalities, understanding, just asking them, what do you have in place? How do you control it? What are the parameters that you put in place in terms of time and how you track it?
Big thank you. Another question, and again, keep these coming in the chat. These are great questions. For achieving the 30-second response time, what does this patient-nurse ratio look like? How big of a pool of patients does each nurse have?
Well, for us, I can speak to ChartSpan. So our team is bifurcated into an outbound team and an inbound team. So the outbound team are the nurses that are assigned to the patients, in perpetuity. So that's kind of their CCM clinical nurse. They only do outbound interactions. When a patient calls in, they call in a 24-hour nurse run line. That is a bank of nurses that will triage, like a traditional triage line. So they're not assigned to specific patients. When those patients call in, they will pull their chart up, verify that it's the right patient, and then they will triage their needs. We follow Schmidt-Thompson protocols, but traditional clinical triage is the system I think we use. And then we, depending on the workflows that have been pre-established by the clinic, by the organization, whether it's urgent, emergent, office visit, prescription, whatever that might be, they'll follow those process map and that workflow based on what the clinic has already established. So that's kind of how we do our breakdown. It's a little bit different between outbound and inbound.
Perfect. Thank you. I don't see any other questions in the chat. Feel free to unmute your line or add them in the chat now if you do have any questions, but thank you for answering those, Shane. Super helpful. Elizabeth, I don't know if you have anything to add in here as well or questions you'd want to further ask.
No, I mean, I think you've done a great job of covering it. Lots of data, which I know can be overwhelming. We will send out the slides so you can pass these along with your team. And pass these along, and feel free to reach out to Shane, Hannah, or myself with further questions. We'd be glad to get back with you. And we're excited. And again, feel free to share your chronic care management stories, because again, I'm telling you, you will not be upset, even though, yes, it takes a little bit of work to start. It's kind of like the 340B drug program. It's in work at the beginning, but then once it gets going, it really can be a great revenue source for your clinics or your hospital and your team, and also by helping you provide great care to your patients. So again, thank you, Shane, and the whole ChartSpan team. We appreciate it. And I hope everybody has a great fall day.